Hey folks, Scott Weingart here, and this is an EMCrit We. A few months ago, I had Dave Zerlink on to discuss hyperbarics for carbon monoxide poisoning, and he basically had concluded there is no evidence for benefit, which doesn't mean there isn't benefit, there's just no good evidence for it. And my plan all along was to bring on people from both sides of the issue. Dave is clearly a skeptic on the quality of the evidence for CO. And I wanted to get someone who's not a rabid hyperbarics defender, but someone who could just give a second opinion. And the person I found who could present the most balanced, middle of the road understanding of where we sit now was Chris Tomaszewski. And brilliant ED doc, toxicologist, out in San Diego. And what I discovered from the interview is a very differing perspective on why we would consider the use of hyperbarics rather than how great the evidence is, though I think Chris feels it's stronger than Dave. But Chris's impression is that what we're really preventing is not immediate injury, but delayed neurologic injury. And that's really the purpose of diving patients after carbon monoxide exposure. He also believes most of the studies were done at too low a pressure and perhaps for not long enough. You'll hear all about that. It's this delayed neurological injury I find most interesting, and it still leaves me questioning where the hell to go if I get a patient with carbon monoxide poisoning. So I think this will be informative to the conversation, and I think you're going to enjoy it. And then I want to hear from you afterwards, based on the compilation of what you know, and maybe having heard these two interviews, and you should definitely go back and listen to Dave's if you haven't. Where do we stand in 2026 on whether or not to dive patients after carbon monoxide poisoning? Who are you and what do you do?
I am Chris Tomaszewski. I'm an emergency department physician at the University of California, San Diego, where I work emergency medicine shifts both in our community hospitals and our mothership. And I'm also a medical toxicologist with the San Diego Poison Center, not to mention that I also do hyperbaric medicine by way of disclosure.
Yeah, which is perfect. Any other disclosures besides the fact that you are doing this on an everyday basis, which is actually a benefit rather than any conflict?
It could be potentially seen as intellectual conflict of interest, but I'm not the person that believes that just because you hammer everything is a nail. I don't think that hyperbarics is a solution to everything.
That's perfect. All right. So with those preliminaries out of the way, we had Dave Zerlink on, and he didn't say that hyperbaric doesn't work. He just said there's an absence of evidence for its benefit. He didn't say there's any evidence against it either, but he left us in a state of true equipoise as to whether diving patients is actually the thing to do for CO. And so I wanted to hear a second opinion. So that's why you're here, Chris. So why don't you start us off with any introductory statement you want to make about the situation as it is?
I know the road to hell is paved with pathophysiological evidence. You think it works in the lab, and then you go out in real life, and it doesn't come true. So that's what I have to say. And I think that's what's happening here with hyperbarics and carbon monoxide.
All right, let's put your feet to the fire. So what would cause you to say this patient should definitely get a dive?
There's two parts to it. What patients should get a dive, in other words, who's at risk for the fretted neurological sequelae, which is real. It's very real. I've had the whole gamut of neurological sequelae, from people having problems with learning and memory and couldn't calculate chemotherapy doses and they're a chemotherapy nurse, all the way to a child getting cortical blindness. It's real. And the phenomena there is neuroplasticity at all ages, but it can take 3, 6, even 12 months before those insults resolve completely. That's the first thing. And then you have to go, who's going to get neurological sequelae? Who's at risk? Who should we even consider escalating to consider hyperbaric oxygen? What's the typical level in a 1 pack a day smoker?
4 or 5?
5%. They have carbon monoxide poisoning. They're not at risk for delayed sequelae. They're at risk for atherosclerosis and all that. I'm not going to throw them in the chamber. So who are we talking about? People that are acutely poisoned, that haven't adapted to that level and are symptomatic, and those are the people that are at risk. And what symptoms are we looking for? Minor symptoms of headache, dizziness, those are resolved. The people that are really at risk are the ones that syncopize, because now they're really at risk for ischemic reperfusion injury. People that comatose or worse that aren't right. What was interesting in Weaver's trial, one of the best known trials, is he found that people that had ataxia or difficulty past pointing, cerebellar signs, also predicted worse outcome. So if you have an episode of headache, little vomiting, and you recover and feel fine, and you have a complete neuro exam, I'm not sure that person really needs hyperbaric oxygen treatment. Are they still at risk? Yeah, but it's pretty low risk. The other thing we're finding is that kids do fine. The older you are, the worse the outcome. I know there shouldn't be an absolute cutoff, but Weaver in another one of his trials came up with age 35 and above had worse outcome. And as we get older, we have less neuroplasticity. That's why an 80-year-old with a head injury is a very different animal than a 2-year-old that bunks or comes in with a cephalohematoma. The older you are, the worse neurosymptoms that haven't recovered from, the more concerned I am that you could have delayed neurological sequelae, and that maybe I need to do something differently. If not only follow you up and make sure that you have follow-up, but maybe we need to consider hyperbaric oxygen if we believe it'll help.
Yes, you've raised two questions, both of which are incredibly pertinent and incredibly important. One is who's at risk for these neurologic sequelae? And then if they are at risk, does diving them make a difference?
Make a difference.
And it sounds like you've given us some parameters for the first question. And I think there's generally pretty good agreement amongst the toxicologists I've spoken about of, I'm concerned about this patient. It's the second question I think is the crux is, so in your heart, do you feel, and I'll ask it in two parts. One, in your heart, do you feel that hyperbarics helps for CO? And then two, given the current state of the evidence, do you think a purely Spockian logical observer who has no emotions should believe it has effect?
All right. So full disclosure, in my heart, I do believe it helps. And that's why we use it at San Diego, at UCSD. We're the only 24-hour chamber. I've accepted transfers from Arizona for carbon monoxide because if you go out, until you get to LA and you go to Tucson, Phoenix, there is no 24-hour hyperbaric center. And so I actually do treat patients with hyperbarics for carbon monoxide, but I don't treat everyone I get a call about. One thing is levels. Everybody wants to hinge themselves on a blood test, right? Let's just do a blood test, and that tells you whether you need to be treated or not. And the problem is the target organ that we're talking about here is the brain, not the hemoglobin. Yes, it does bind to hemoglobin, 200 to 300 times better than oxygen. But I can clear that with 100% rebreather mask. Sure. I can do that NED. By the time I get them to the chamber, most of the time, most people have cleared most of their carboxyhemoglobin. What I'm doing is to prevent the inflammatory disease. Carbon monoxide poisoning is an inflammatory disease. If you look at the studies that look at white blood cells in people that are exposed to CO, they're sticky, and they stick to the microvasculature of the brain. And they release a lot of nasty enzymes, metalloperoxidase, and they cause a whole cascade of events down the road after the reperfusion that results in this phenomena of delayed and, in some cases, persistent neurological sequelae. That's the problem. You're measuring a blood level to try to figure out what's going on in the brain. No, that's not going to correlate because, for example, they actually took Duke medical students. I guess they needed letters of recommendation, and they gave them a quick exposure and got their levels up to over 20%. And they weren't that sick. Whereas you have somebody with a bad furnace soaking all night or a bad muffler in their car for hours and hours at a low level, their area in the curve, their level may not be as high, but their area in the curve is higher, and they're more at risk for these phenomena. And the other thing is, when people measure level, were they on oxygen before you measured it? How long were they on oxygen? What was the transport time? But you're measuring at all different times, and that's why we haven't been able to hang our hat on exact level. But if I get a patient with a level over 20%, let's say, carboxyhemoglobin, I even get nervous about 10% because even a 2-pack-a-day smoker doesn't get about 10%. But 20%, you have to ask yourself why you're not using hyperbaric oxygen. There is a carbonmonoxidelawyer.com who's very adept. So at least you have to ask yourself, why am I not going to use hyperbaric? You say you can have the discussion with the patient. We don't have hyperbarics here. The nearest hyperbarics it could be a 6-hour flight. If you're in Alaska, there's no 24-hour chamber. They have to transfer those people to Seattle. If you're Montana, there's no chamber for the small potential benefit. And remember, the other thing that I think is important, if you're going to talk about hyperbarics, it's time to treatment. I really, in my heart of heart, believe that the sooner you do it, the better it works. And I think, what do I mean by sooner? There's no absolute drop off. But I think if you're getting to more than 6 hours, you're going to have less efficacy. And I think that's why we're seeing some studies have come out, and in fact, some have randomized, but patients were treated very late.
Yeah.
And I know there's yahoos, I don't know what you call them, in the Midwest that actually die people days to weeks after their carbon monoxide poisoning for these delayed sequelae, and they claim they show some improvement. I think some of that's just salutatory or placebo effect. And remember, people dive kids for cerebral palsy, and they actually get better. But what's the natural course of these diseases? They get therapy, people figure out ways to work around, or their brain function improves. Even after, we say it with strokes, right? Stroke victims get better with time. They're not all stuck with the exact same deficits we saw when they were at their worst. So that's but again, time to treatment matters. So if I get a call from Bakersfield and they're already hours post-exposure, now they want to transfer, why don't you have a discussion with the patient? Do they really want to come if they only have mild symptoms? When I don't think it's going to help that much.
Yeah. All of that makes sense. You mentioned one thing that I think is absolutely different between the practice we have in the United States and Dave's, which is he's in Canada. And I pointed this out to him. I'm like, what you're saying is completely logical, but you don't have the medical legal system we have. So that right there is one potential reason in the United States. Let's take that off the table.
Yeah, but you can fight that by documenting everything. Sure. Just say, we thought about hyperbarics, but we didn't think it would help.
Yeah,
at least you preempt it by having a good offense. So they go, doctor, you didn't even think this patient could have appendicitis, did you? Oh, no, I put it on my chart, considered hepatitis, but we ruled it out. Shared decision-making, whatever. I examined the patient, negative Rosfix. We do the same thing for other diseases. So hyperbarics is well known enough that at least you should have the discussion and document it. Even if you don't think it works, at least we talked about it, and I advise the patient against it because the data is incomplete.
I think that's inarguable. Yeah, I totally agree that to not have that on your chart on a patient who presents would be insane. But let's really delve in. I'll give you the hypothetical case that spurred me investigating all of this, because I've always been in places, always level 1 trauma center, academic places, but I've never been in a place that had hyperbarics, except for my trauma center where we wouldn't deal with the medical side of it. So we only did it for neck fascia and things like that. So I've never really been exposed to being at the center that had to make the decisions. So I would always transfer patients. And I'd come from a training path where I just thought hyperbarics is the antidote to CO. So we would call, they'd accept in almost every case. And then I wouldn't have no idea if they actually got dived or not. So I didn't have to deal with it. Then I moved to a new center and we had a patient come in, and her level was 32.
Wow.
She was completely out of it. She wasn't comatose, but couldn't talk, didn't respond to any commands, just sitting there almost like a mutism patient. And then we saw that level, and it was a suicide attempt. She put a snowblower into the garage and just left it running. Smart, because the catalytic converters, most of the cars won't do it so well, but figured out a way. Probably used a chat GPT or what have you. And I called up my hyperbaric folks, and I'm like, you need to dive this patient. And they're like, will they clear their eustachian tubes? And I'm like, no, it won't do anything. And they're like, I don't think we should dive because she's going to have a massive ear rupture. And I'm like, wait, what? They're like, if intubated, it would be fine, or if she followed commands, it would be fine, but we can't dive like this. And I'm like, well, that's crazy. You're telling me that if she was better, it was good enough that if she could swallow, you'd dive her, but now you're not. And I'm like, I'm like, I'll intubate. And they're like, no, we don't think you need to. We think they'll be fine. And then I'm like, this makes no sense. And I called up the tox center, and they're like, you probably should dive this guy. And then I called up the CMO, and she had a conversation. And while all this is going on, the patient got better. And
now's the time. Now you can put them in the chamber.
But then they're like, she's so better, and she was like pristine. And this is the next question I want to ask you, but don't go there yet. I know that's the more you want to salivate over is delayed versus obvious neurologic quality. But the question I'll have for you first is that a guy, you obviously would have dived that patient. How do you deal with the issue of they can't follow commands or clear their auditory passages?
That's funny. We did publish a paper where we interviewed every hyperbaric center in the U.S. to say, what do you do about ears where people can't clear their ears? And Nobody ever had to scrape a stapes or a malleus off the side of a chamber. Could you rupture? Potentially, but even these people on vents don't rupture. And right now we're doing a head injury study with hyperbarics, and we're supposed to poke their ears. And it's really easy to poke an eardrum. You just grab a spinal needle, bend it at 45, 60 degrees, and I just go through the otoscope and just poke go to the light, go to the light. You just poke and it makes it easy. I don't have to worry about them rupturing an eardrum. But at worst, there were a few cases where people did rupture eardrums that couldn't clear their ears. It's not the end of the world. They're not going to lose their hearing for life. And yeah, maybe one day they might need a patch because it doesn't heal, or you get a cholesteatoma or whatever. But at the end of the day, I would think preventing that neurological sequelae would be more important, especially a case like that. But remember.
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this, and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Yeah, these people do tend to get better with oxygen. So by the time they get transferred, the chamber gets prepped. That takes hours to get everything set up, right? They should have just taken it.
Well, you've hit my exact question. And thank you for talking about how easy it is to poke, because that was my exact thought. And they just told me, Scott, you're not credentialed for this. You're not allowed. Which, if they hadn't said it, then I would have asked for forgiveness rather than
But you're an emergency doctor, right? We can do anything. I've had my ER docs trepanate people out at a rural
I would do that until they told me I couldn't. It's just a question of...
Wait, it's not on their credentials list. I go, CNO, it's an emergency. I'm sorry. We're ED docs. We're allowed to do things if it's an emergency.
Yeah.
And there's no other choice. And document, obviously. But.
Yes. Okay. So now you would have dived that guy initially, and now hearing that the worst is not that bad compared to delayed neurological sequelae, that's great to hear. Once he woke up, tell me about the pristine neuroexam and then how many patients go on to have neurologic sequelae.
Pristine.
Yeah, she was like legitimately back to baseline.
Pretty sick.
Yep.
The level is pretty high, and I told you the level is not that great. But that's a significant exposure. I don't know, 20 to 40% chance of significant delayed sequelae, somewhere in that range. So go ahead. Over half the patients or more, even a Weaver study did well, right? Even sick patients, a lot of them do well. So you can tell patients, you have more than half the chance if you don't like the idea of being transferred or going to chamber, or you have a dog you need to go take care at home, over half the patients do well, but still a big proportion do have these sequelae. Even with the sequelae, some of them get better. Go ahead.
How many of these patients, and you might be answering this already, but I just want to make really sure that we're talking about the same thing. How many of the patients have the interim neuroexam where they seemingly, and you could even did cerebellar testing on this guy and memory testing, how many of them have the delayed neurologic sequelae with a period of return to full baseline? We're talking like an epidural type situation here, right? They had a lucid period and then go on to their negative sequelae. How many, was that ever studied of patients? Is a good neurologic...
Yes, it does happen. What percent? I can't give you an exact percent. I bet for somebody like that, every case is different, right? For your case, that sick, I bet, I don't know, a quarter of a chance, more than 20% chance of having something significant happen. You have people that seemingly look great, and over the next couple of days, they go, you know what? Unless you do good neuropsych testing, you're not going to detect it. Or unless they're an accountant and it's tax season, and suddenly sick. These numbers aren't making sense. Without a good MOCA or good neuropsych testing, you may be missing in a week from now when you have them come back. I bet there's a good chance you may have some issues.
Interesting. All right. Let's say you were an expert witness and they asked, would you represent We just need, Doc, we don't want to hear personal opinions. We don't want to hear your heart. We have this doc getting sued, and the doc wrote in their chart, based on my review of the evidence, hyperbaric has no positive support for changing neurologic sequelae. And therefore, though I strongly considered, I elected not to dive the patient. Would you support that doc of saying, that, while it might not be your interpretation of the current state of play, that they're not wrong?
I've been in those shoes helping somebody over 20 years ago. And because of that case, I no longer do medical legal stuff.
Okay, let's pretend.
And I do. The reason I don't do it is because the whole game is not to find out what the truth is. It's to win the argument.
Sure.
So if everybody was collectively trying to find the truth, I would be more interested. Anyway, it's context. Are they in rural Nevada and the nearest chamber is 6 hours away? They're going to have to get a flight. By the time they get here, I don't think it's going to help. How sick were they? I don't want to throw anybody under the bus, but
this is purely hypothetical. You could throw them under the bus and do all sorts of philosophical things.
Consider hyperbarics and talk to the patient about it, because maybe we need to go back to the foundation. So let's go back to the animal that most people hate, the rat, right? If you go to rodent studies, it looks like it really does work. Now, I did a study where it didn't seem to help, but everybody says I made my animals too sick, so they were having anoxic damage. But if you look at it, there are a lot of animal studies that not only support that it helps with their neurocognitives, they're smarter rats, they're less dumb after they get treated with hyperbaric after CO. You can actually see the leukocytes after you give even human leukocytes hyperbaric treatment after CO poisoning, they don't stick. So there's something going on physiologically. Is that a patient-centered outcome? Absolutely not. But so foundationally, it seems to make sense. And then we have both Steve Thom in Philly and Lynn Weaver in Utah do these very well-controlled studies and show a pretty good difference, a dramatic. Not everyone's protected. People are getting sick. So it's not a panacea. But if you look at Weaver, the number needed to treat was 5. So for a very benign treatment. Right.
Weaver did not have, there were some big, huge problems with that study, not the least of which is changing the primary outcome post results.
And also how you measure cognitive outcome.
You
group some of the neuropsych testing. In his defense, he said that's the way neuropsych testing is done. And then in his defense also, he said some of these people had profound deficits. So anyway, because of Weaver's study, I had those criticisms as well. And then Steve Thom did a pretty good study and showed a difference. Again, these are very well-controlled studies. They pick their patients very well, right? This is efficacy versus efficiency. This is why, I don't know, if on some of your podcasts you talk about Ioannidis. Have you ever discussed him?
No.
The mathematician at UCSF, who says more often than not, a third of studies are wrong. In other words, a third of published studies, when they go to replicate them, they come out no difference or worse. Because a controlled study where you're making sure these patients get there early, you're giving them an optimal treatment, you exclude people that may be outliers, you're very real controlled. That's efficacy. When you go to real life and test that out in terms of efficiency, it never works out that well. And that's why the Nakajima study is interesting. It's a propensity study. We had thousands of patients. And he did show a small improvement in the group that got hyperbarics. But the delta, the absolute risk reduction, wasn't that much. So there's a signal there. And if I had a CO patient walk into UCSD, I get the chamber down there, I'm doing the right pressure. A lot of these studies don't even do the right pressure or the right duration of treatment. Would we take a clinical trial, a pharmaceutical trial, where they gave half the dose that you're supposed to give? We'd throw that out. So that's the problem with some of these studies. But you're right. The little nuances in Weaver study make me feel better about defending that doctor not using hyperbarics, especially if they discussed it with the patient and they wrote down why they're not doing it.
Let's say a consortium came to you and said, we're taking every patient in the United States and we're randomizing them to sham dive versus real dive. We're finally going to settle this question. Would you think it's ethical for you to randomize your patients, Chris?
And these are going to be ones that are at risk for, you're going to pick out the sickest of the sick, probably.
You look at the protocol, you're like, oh, this is it. This is it. They're choosing only patients that deserve to be dived in the first place. Everything looks perfect. Would you sign your center up for that study if you had input into it?
I would first do a really good study with late treatment versus early. And if you show me a dose response curve in terms of time to treatment, that the early ones, because I don't think late it works.
Okay.
So let's do that study first. Let's get people that 6 to 24 hours or 12 to 24 hours or even later versus people that get 0 to 6. And you're right, it's not a good RCT trial. But the one you're describing, I'd have a hard time entering people in that because in my heart of heart, based on the pathophysiology, based on Weaver and Thom study, and based on some of these propensity studies, I bet it helps under certain conditions. Certain patients that are high risk, that are treated early with the appropriate pressure, probably get some benefit. And it's so benign. Now, am I going to move people across? If you're in Alaska, I had an associate that ran the Seattle chamber, and he got a call from Seattle. They were in debate. He said, don't bother sending them. The risk of the transport is worse than the potential for this delayed neurological. In some cases, it's not permanent anyway.
Okay, let's just dwell on that for 2 seconds. So you mentioned the number 12 hours. We could get most patients who aren't in Alaska to a chamber and get dive within 12 hours. Other people have suggested 6, which really, the difference between those two numbers is enormous in terms of capability of transfers actually making things happen. And it seems like that hospital is only an hour away. It shouldn't take more than an hour to get them there, and yet it takes 6 hours every time. It's just insane. Right. So what is your cutoff for a transfer center calling you, and you look at the time, and it's been 3 hours since exposure, it's going to be an hour and a half on the road. Is that patient worth transferring? What's your cutoff?
If it's been more than 6 hours and they look fine, I'd probably say, you want to come, we're available, but we understand it's probably minimal benefit, is what my gut tells me. Even though I know Weaver entered almost half of his patients were 6 to 24 hours.
Yep.
And the other study we all look at is the Schinkenstiel study out of Australia, which had a well-randomized study. A lot of those patients were dove late. Yep. And I think they only did an hour of treatment. But a lot of those patients were depressed. Over half of them were suicide. And I don't know if you know this, but we're starting to know studies, even with MRI and with neurocognitive testing, that people with chronic depression actually have neurocognitive deficits. It does affect learning and memory in those people.
That's fascinating.
So is that a different population? Is it a different population that somebody who's had long, severe depression to the point that they have to use CO? That it may not make a difference if we dye them or not. That's
fascinating. So there need to be a stratification in the study for those patients versus not. Yeah, that's fascinating. All right.
You're bringing up good points.
Yeah.
And you could call this podcast wishy-washy because that's
what you're supposed to do when there's not clear definitive evidence. So that's appropriate for a scientist. All right. There's a therapy called isocapnic hyperventilation where, feeding the patient carbon dioxide actually makes them hyperventilate. And the companies, at least, have stated that they have rates of clearance of blood as quick as hyperbaric. From everything I'm hearing, I think that probably wouldn't blow your socks off anyway, because that doesn't matter to you as much as the effects of the actual inflammatory cascade. So tell me, is that therapy have any weight? Have you ever heard of it? Have you ever had anyone do this? And if you just had to think of it mechanistically, is there any benefit to it?
So now we're starting to confuse. The treatment is not to clear carboxyhemoglobin. All right. The treatment is to prevent the inflammatory cascade. The same reason we use it for decompression illness. There's an inflammatory cascade there, which is, I'm not going to digress. But so we can clear carboxyhemoglobin with 100% oxygen. It'll just take longer. I'm not sure that everybody showed the rate of clearance is what improves outcome. And I reviewed an article for one of the journals I review for, or as editor, where they looked at high flow nasal oxygen. And look, we cleared the carboxyhemoglobin a lot faster. And I go, yeah, that's awesome. But does it change the outcome? And nobody's shown that changes your issue. Once you start getting to 2.5 atmospheres, that's 1.5 atmospheres above what we are right now. We're at 1 atmosphere. That's why it's hard to get up Monday morning, because you have 1 atmosphere of air pushing 14.7 pounds a square inch pushing down on you.
I think it was the bourbons the night before, Chris, but okay, go with the atmosphere.
It'll feel like 2 atmospheres in the morning. But once you start getting to 2.5, in animal studies, we all do the animal studies at 3. That's when Lynn Weaver did his study. That's when you start seeing these anti-inflammatory effects. And that's why we take our decompression illness to at least 2.4, 2.5 or higher atmospheres. That's when you start making a difference. And I think that's what the issue is with these studies that use these lower pressures.
We were asking specifically, and I'll edit this down, about the isocapnic
Oh, yeah, the
hyperventilation.
hypercapnic. Yeah,
and
so
I think you've already answered it, but I just want to hear you
Yeah.
really say it definitively that you don't care about the blood clearance as much as the
No,
anti-inflammatory.
and that's why I have a problem when you call a hyperbaric. When you're an ED doc, I work in a rural. I work part-time in a rural. You call a hyperbaric center and they go, "What's their level now? Their level's only 4%. Why would you bother transferring them?" I'm not transferring them to clear carboxyhemoglobin. I can do that with a face mask, or I can go buy the hypercapnic device, whatever. No, I'm sending them to you to try to prevent the delayed sequelae. And there's another devil in the details, and that's the heart.
Yes. Tell us about that.
That's scary. I'm starting to look at all this data, especially Korea has a ton of CO poisoning. Partly, I don't know if you know this. I don't know if you lived in Korea or any Korean listeners, but what a traditional Korean home has a charcoal pit in the center for heating. And in fact, Korea has more hyperbaric chambers per capita than the U.S. And they die of a lot of CO. And their criteria are not always clear, but they've noticed that they follow their patients because they have one EMR for the whole country. So they know what's happening to everybody. And they're seeing with months to years after the CO poisoning, these people are dropping off like flies.
Oh, interesting.
The incidence of cardiac mortality, cardiac death, congestive heart failure is higher in the people that are exposed to CO. A lot of them got hyperbarics. So there may be a phenomena of delayed cardiac sequelae.
Yeah.
And I've noticed on some of these high resolution functional MRIs, they're actually showing myelofibrosis within the heart. I know my wife doesn't allow anything with a face or that makes babies in the house. We're not allowed to eat meat, but I'm a flexitarian, by the way. But if you go to the supermarket and you look at steak, what color is it?
It's red.
Right. But have you ever had venison? Venison's dark.
Yep.
Because it's deoxygenated myoglobin.
Absolutely.
It shouldn't be bright red. It's bright red because they gas it with carbon monoxide at the packing plant.
Yep.
That same affinity, your myoglobin in your heart has a 60-time affinity for carbon monoxide versus oxygen. And there's an inflammatory response for the heart. And some of these patients have a decreased ejection fraction acutely that slowly improves. But even then, I think they're still at risk for these delayed effects. Does hyperbarics prevent that? I don't know. I hope it does. But if it does, then why in Korea are they having all these incidents, and some of these people that even got hyperbarics are still having congestive heart failure? And I think they're dying from dysrhythmias is what's happening.
Wow, that's fascinating. I mentioned screening for the early phase of cardiac complications in the last podcast, but I never thought of delayed. So they actually probably need cardiology follow-up as well to screen these patients long-term. Wow, that's super cool. Chris, I'm sure there's something I missed that you want to get out there to the audience. Tell me, what did I not hit that we should have discussed? And the answer could always be, Scott, you were so complete, you don't have anything that we didn't hit. That's fine too.
Scott, you're amazing.
No, I don't need
You gave me $10 to say that.
Yes.
You are complete. You hit it all. We went from the lab, it sounded like a great idea at the in vitro level with the white cells. The in vivo level, the rats seem to do better. The well-controlled human studies seem to do well. But then again, are we fudging the data to make it look good on some of these studies? But there's a signal there. There's something going on there. But then when we get out to real life, what these other trials that people publish that haven't shown that much difference, there's a little bit of improvement, like the Nakajima study, but it's not that great. And then a lot of people keep doing meta-analyses. And if you take 3 second graders, you don't get a 6th grader, right? That's when there's studies that prove that, right? So there's something there. If you got a chamber close by, you can say this. I would think the best thing to do is tell the patient, this is low risk, it may help, and it's nearby, or you're at low risk. Remember, the chamber is so far away, by the time you get there, it's probably not going to help. Do you really want to go? And by the way, you're going to have to be locked in that chamber for 2 hours. Do you know that? And some people say, you know what, I'll take my chances. And just warn them, you may have some problems over the next couple of weeks or two. See how you do. The good news is a lot of people, as you follow them, do show some improvement. Even though in some cases, they're actually showing MRI changes in people exposed to CO. You do see some periventricular white matter changes. And God forbid you affect the seahorse of the brain, right? The hippocampus, which is really important for learning and memory. So remember, just because you look good neurologically, either acutely or down the road, until you do good neurocognitive testing, you may be missing, that these patients may have some subtle problems, and that needs to be dealt with, regardless of whether they get hyperbarics or not.
Chris, that was fantastic. Can't thank you enough. So happy you came on the show.
Cool. That was fun.
Have a wonderful weekend, man.
You too.
Bye-bye. As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to EMCrit.org/stuff. EMCrit.org/stuff. That's EMCrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.